This is the voiceover PowerPoint for NURS 1202, Chapter 32, Women's Health. Uh, we are talking here about a women's health initiative. The National Heart, Lung, and Blood Institute was formed and it began in 1991, and they started this initiative with trying to make women's health improve, preventive health in particular, especially for postmenopausal women, because there is increased risk for cardiovascular disease in postmenopausal women. And it's in all women, but in particular the postmenopausal woman, because of the decrease in estrogen production. There's breast cancer problems, colorectal problems, and of course osteoporosis. And the Healthy People 2021 initiative also adopted 13 new topics concerning women's health. And I've given you a reference here. I don't expect you necessarily to memorize it, but there's some good information there as far as we can help promote women's health. So health maintenance is very, very important. We've talked about this quite a bit and how it's important to educate our patients about their health and how they can improve their health. Women have examinations and screening procedures that allow early detection of specific conditions, in particular breast cancer and cervical cancer. The breast cancer, of course, being the mammogram, the breast self-examination. They can do ultrasounds of the breasts, different things they can do. And then, of course, the cervical cancer can often be detected through the pap smear and the well woman exam, the pelvic exam, and the pap smear. And by doing this, we can find them early enough, and we can have better treatment, and we have much better outcomes as far as our long-term survival rates. Unfortunately, many women do not take advantage of this because of possibly where they live. The services are not readily available. They're worried about expense, maybe have no insurance. They're worried about maybe having some bad news delivered to them, or they've heard terrible things about the exam, how painful it is, how awful it might be, etc., etc. And sometimes they just don't feel like it's necessary because they're young and they're healthy and whatever. So I also have pointed out here another reference for you in your book table, if you will. And so we want to encourage women to take part in these, and especially we want to talk to the woman about doing her own breast self-exams. Now, it's very important to remember that a woman knows her own body better than anybody, and that she should and probably will notice any small changes that might occur. And so we want to make sure that she understands and has the tools that she needs to do these things for herself, and then if there's anything unusual that she notices, then she can report that to her healthcare provider, and hopefully interventions can be made. And you can see here it says do this once a month, a week after your period. At that time, the breasts are more soft, they're less tender, and so it's a good time to do it. Also, in postmenopausal women, they also need to do a self-exam, and they usually typically recommend they do that on the day of their birthday. So for instance, my birthday is the 21st of February. I would do it on the 21st of every month so that I would not forget. And then you see here the steps for the breast self-exam. It's not exact order, but we do recommend that there is some systematic procedure to it. And in particular, that lower middle picture where it talks about the underarm area and around, that's on that upper outer part of that breast is called the tail of Spence, S-P-E-N-C-E. And that is a very common area for lumps to be found. And so we're really wanting to kind of fixate on that that area. Also know that we just talked about the cervical cancer and the pap smear. Also know that women are encouraged, depending on their issues, usually it's a yearly exam if they're healthy, more often if it's, whatever, but the pelvic exam is one of the cornerstones of healthy GYN services, and so the woman will come in and talk with her healthcare provider, where it be a physician or a nurse practitioner, and they will get a health history. They will do some vital signs, get her height and her weight, the typical things of going to the doctor's office. And then they will talk with her about her concerns or her complaint, and then they will prepare her for the examination. Of course, she'll have to remove all of her clothing, put on a gown, and it's very cold, so remember that. Sometimes women need a little blanket, and then they will help the woman into what is known as the lithotomy position. Now, this picture is more related to a surgical area, because the woman has a thing on her head and she doesn't have any clothes on, it looks like. But in an office, the woman doesn't necessarily have to have anything on her head. She has a pillow, she has a gown on, she may have a blanket, but she will have her legs up in the stirrups, and the perineum will be exposed. And so they will do, first they'll do the pap smear. They will not use any kind of lubricants or anything like that. They will do the pap smear, and they will do that with a speculum. And it's a vaginal speculum that's inserted in the vagina, and then it's the little blades open so that they can visualize inside and see the cervix with a light. The one on the left is a plastic one. It's thrown away after one use. The other one is a metal one, and typically it's very cold, and they are obviously reused and sterilized and reused. And then going back to the picture, the bimanual examination is the fingers in the vagina and the other hand on the abdomen, palpating the uterus and the ovaries, and they can feel masses. They can kind of feel the size of things, and so on. I went ahead with my slide too soon. Sorry about that. Okay. Now, moving on to breast disorders, we're not going to spend a lot of time on this because you'll get a lot of information about breast cancer and so forth in your med surg course. And so we're just going to mention a few of these. Benign breast disorders, they're not necessarily, they won't be malignant, they probably won't turn malignant, but they can be concerning and need to be investigated. Fibrocystic breast disease, fibroadenomas, and so forth. Those can kind of be problematic, and if a woman discovers these, or the physician says, yeah, this is a problem you have, they'll just do watchful waiting and kind of keep an eye on it. And then, of course, the malignant tumors of the breast. Breast cancer is a very high, causes a lot of deaths in women. 1 in 8 women here, it says, will develop breast cancer in their lifetime. So that breast self-exam and the mammograms are very, very important. And you'll learn, again, more about that in your med surg course. Here are some risks for breast cancer development. Being female, although males can develop breast cancer, it's kind of unusual, but they can. Being older than 55 years increases your risk, but of course we all know and have heard maybe of someone in their early or late 20s, early 30s getting breast cancer. Caucasian race and is also a risk factor. Early menarche or early onset of menses or late menopause. Multiparity or first pregnancy, nulliparity, or first pregnancy after 30 years of age. Personal history of breast cancer. Genetic risk factors, that's that BRCA1 and BRCA2 gene that they've identified as being a risk factor for breast cancer. Apparently, actress Angelina Jolie was tested for this, and she found that she had both, and she had her breasts removed and reconstructive surgery done. I had a former student who had the BRCA1 gene, and she had a mastectomy and had reconstruction, and she was having her daughters tested. Previous irradiation of the chest area for whatever reason. Previous abnormal breast biopsy results. Maybe they found a lump. They did a needle biopsy, found that it was cancerous, but they removed the lump and everything was okay. Long-term hormone replacement therapy with estrogen and progesterone increases the risk of breast cancer, a big one there. Excessive alcohol consumption, overweight or obesity, and even physical inactivity can be a risk factor for breast cancer. And here is a picture of the breast divided into 4 quadrants, and you can see that upper quadrant there. About 50% of all breast cancers develop in that's called the tail of Spence, and that's very, very important to remember as far as breast exams. Always check in that area very extensively. So for breast cancer, we're just going to mention these briefly. Surgical removal of the tumor and maybe the surrounding tissue and lymph nodes, that's called a mastectomy, or either modified tissue saving. There's different ones they do now. Adjuvant therapy, that might be something like the drug tamoxifen or Evista. Radiation, chemo, hormonal therapy, and immunotherapy can also be used in the treatment of after a breast removed or something like that. Okay. Cardiovascular disease, of course, is a leading cause of death for women, and oftentimes women don't present with the typical symptoms to your ER with, the classic signs of pain radiating down the arm, sweating, pale, knife-like, feels like an elephant sitting on my chest kind of stuff. They'll have kind of vague symptomology sometimes, and many times they are not taken seriously, and they're labeled as anxiety or depressed. They're sent home with medicine that's not effective, and then they go home and have a real heart attack. So always pay attention to that, because remember, people do not fit in nice little neat categories. They sometimes don't fit in little boxes. Preventive measures for cardiovascular disease, and this is stuff you've heard before many times. Control the blood pressure, quit smoking, modify your diet, low fat, low carb, etc. Get your blood sugars under control. Sometimes low dose aspirin may be prescribed as an antiplatelet to reduce the risk of thrombosis, and of course increase the activity level. And here, this is directly from your book, as you can see, risk factors for coronary artery disease in women. And so you've got elevated cholesterol, low HDLs, cholesterol ratios are bad, triglycerides are high, you've got diabetes, overweight, sedentary lifestyle, poor nutrition, older than 60, postmenopausal status, and family history. These are all things that you already know. Okay, so now let's talk about some common menstrual cycle disorders. And we mentioned this a little bit in class. Amenorrhea, absence of menstrual flow, all right? It's a clinical sign of many other problems. It's not a disease itself. It could be a sign of something. Most of the time, we expect the menses to start by age 14. Okay, there might be a year or two difference in different references, but that's pretty much normal. If absence of menses by age 16 might be a problem, and that we call that the primary. And then a 3 to 6 month absence of menses after a period of menstruation called secondary. But although the most common reason there's amenorrhea, of course, is because of pregnancy. Sometimes this amenorrhea can be due to a pituitary problem, can be exercise induced or exercise associated, especially those, I read that it said sports that require low body weight, like gymnastics, swimming, volleyball, and all those kind of things can lead to that. They also think that it could be a lack of ovarian hormone secretion, and so it needs to be investigated. In particular, if menses are quite late coming along, they might want to investigate that and see what's going on. They may do some hormonal levels and so forth. But by age 14, most girls have started their periods. Sometimes it may be later than that, and it may be fine, but it's always something that we might want to investigate. Abnormal uterine bleeding, or dysfunctional bleeding, we call it, occurs with abnormal frequency. You may go several weeks without any bleeding at all, and then you may have breakthrough bleeding between your cycles. Could be any number of those things. Sometimes they last longer than they should. You may have had a regular menstrual period, and then 3 or 4 or 5 days later, you start bleeding again, and it could be a hormone problem. It could be something else. Um, and so lots of times too, the flow is quite heavy, and so this is something that needs to be investigated as well. It could be a hormonal problem, like I said, a structural problem, something else possibly going on. So anytime there's a disturbance like this, a woman should probably see her healthcare provider. Now, there is pain associated with the menstrual cycle. Some women say they can tell when they are ovulating because they get little pains in their abdomen. And it's called Mittelschmerz. It's German for middle pain. It kind of can be on one side or the other. And some women can actually say they know when they're ovulating because they get this little pain. It's not always a tried and true scientific thing, but they can pinpoint it sometimes. We also have something called dysmenorrhea, which we talked a little bit about. This dysmenorrhea, of course, is pain during or shortly before menstrual periods start. Primary dysmenorrhea is caused by, it's a condition associated with ovulatory cycle problems. Excessive release of prostaglandins causes pain. This is something to remember. They think that primary dysmenorrhea could be caused by an excessive release of prostaglandins that causes pain. The body releases its own. Of course, we can give prostaglandins as well for other things, but that might be the reason. And so alleviating discomfort is our goal, of course. And so things like, NSAIDs, heating pads to the abdomen, just rest, take it seriously. And sometimes during the menstrual period, there will be a lot of cramping, and not just a little cramping. It's really excessive. It could be backaches, leg cramps, nausea, vomiting, diarrhea. That's pretty significant. Oftentimes, during the period when the pain is so bad, we can give the NSAIDs, and then of course we can also give. Sometimes in the treatment of this, they may decide to use oral contraceptives, and that sometimes is helpful. Endometriosis is, of course, there is endometrial, I'll say it in a minute, endometrial or presence of the growth of endometrial tissue outside of the uterus. And it occurs in about 5 to 15% of women in their reproductive age, 30 to 45% in infertile women, and 33% in women with chronic pelvic pain. Major symptoms are the dysmenorrhea, deep pelvic dyspareunia, which of course is painful intercourse. Drug therapy may be necessary. Again, NSAIDs. There may be some drugs that will help shrink the lesions. Sometimes there has to be surgery done. Sometimes it can cause lots of scar tissue and adhesions, which can influence fertility, can actually lead to infertility. Some people have actually had such bad endometriosis and such bad pain and could not get it under control. They actually ended up having a hysterectomy, which of course is called induced menopause. And sometimes they can go in and what we do an ablation, where they kind of scrape and kind of heat, like a cauterization almost, of those lesions. So there's different treatments, but it is something that's quite common, and it has to be treated somehow, because the quality of life for the woman can be quite bad, because it can really mess with her life, her relationships, and so forth. Okay, and then we're going to talk about premenstrual syndrome in just a moment. But here's a picture of common sites of endometriosis. Okay, so we're going to talk about PMS. premenstrual syndrome, PMS. I'm trying to find my notes, so sorry about the rifling of papers here. Well, no. Okay. So premenstrual syndrome, as you can see here, has several little symptoms, if you will. And while I'm thinking of the menstrual disorders, let me stop here just a minute. And we talked about some of these terms the other day. We've got the menorrhagia, okay, lots of bleeding. And anytime a woman has a really heavy menstrual period, we always have to be alert for anemia because a lot of women can lose a lot of blood with just menstrual periods. Okay, now, I'm sorry, we're jumping back to PMS, and it's in order for it to be true PMS, the American College of Obstetricians and Gynecologists say it has to be cyclic, that it has to occur more than once, etc., etc. And so usually it starts to occur about 5 days before the menstrual period starts. You can see here some of the symptoms are depression, and we're not talking about clinical depression, just not feeling well, not wanting to go out, wanting to stay in, lay in bed, that kind of stuff. It's short-lived. It's not incapacitating for very long. Irritability, being very irritable and short-tempered possibly. Sometimes insomnia is a problem. They often feel bloated and their abdomen feels bloated to them and they're uncomfortable. They can have headache, and sometimes with the bloating they'll retain fluid with it, and they'll, as you see here, this is kind of like a little calendar that some women want to keep just to kind of, keep them on track of what's going on and make sure that they can kind of handle it. Let's see, anything else here about PMS? It's a real thing. It's not just, and we often joke about it and, oh, she's on PMS or whatever, but it definitely is a problem. And so there may be several things that we may advise the woman to do as far as managing her PMS. Lots of times we'll tell them to avoid salty foods because of the fluid retention and bloating. Sometimes they want them to lay off caffeine for a while because they may have some breast tenderness as well, and caffeine seems to aggravate that. Chocolate is another one that they may want to lay off. They want to make sure that they stay active and get plenty of water and exercise, eat good fresh fruits and vegetables, that kind of stuff. And then usually once the menstrual period starts, a couple of days into it, the symptoms pretty much go away, and then they're pretty much all right, and then everything's good, and then we go through that cycle again, possibly. So again, it has to be cyclic in order for it to be a true PMS. Now, PMS can actually be very exaggerated and can actually become a psychiatric issue with a very, very severe form of PMS, but you will learn about that in your mental health course. So PMS is real. We need to help them deal with it. Sometimes they may give them a mild diuretic, and sometimes it's just symptom control. Okay. So here is some more information about PMS. Here are your symptoms. I would make sure you read that chart or that box there. I'd make sure you did that. I would also make sure that you looked over this, how to relieve the symptoms of premenstrual symptoms. You see here a lot of things about diet, exercise, stress management, sleep and rest, etc. Okay. So an abortion, induced abortion, is the termination or purposeful termination, if you will, of a pregnancy before 20 weeks. All right, before 20 weeks. Now, typically we hope most women do not wait until they're 20 weeks or more before they decide to do this, although it's becoming more common. But abortion, of course, is a spontaneous abortion, we know, is also the same as a miscarriage. This is one that a woman is pregnant and she decides she does not want to keep the baby, she does not want to go the pregnancy and let the baby be adopted out, she wants to terminate the pregnancy. And so it's elective, it can be therapeutic. You know, there's always that argument, oh, well, it's done to save the mother's life. There is a lot of evidence that suggests this is not true, that there's very little risk to the mother. There's a lot more risk to the baby. Sometimes there are obvious genetic disorders, and maybe in some instances of rape and incest, it may be done. So, elective termination of pregnancy. There's medical methods and there's surgical methods. And you see here within the first 7 weeks of the last menstrual period, we can use medications. And the mifepristone, also known as RU, capital letters RU486. Then we see methotrexate and misoprostol. We've seen those drugs before, haven't we? We remember that the methotrexate was used in that ectopic pregnancy that had not ruptured, was not a surgical emergency. The woman could take the methotrexate and essentially kind of let that pregnancy die, and the products would be absorbed by the body and all was well. And sometimes they'll give the RU486 with misoprostol. Now remember, misoprostol is a drug we give to treat NSAID-induced peptic ulcers. And on the label it says that pregnant women should not take it because they will abort. Well, we also know that at term pregnancy, when we are wanting labor to start, oftentimes misoprostol, also known as Cytotec, can be used to stimulate labor. But in early pregnancy, it is often given to induce abortion or get rid of a pregnancy. Okay. Now, if this does not work, then we would turn to the surgical methods. We would do what's called a dilation and evacuation, and you could also do a D&C. Okay. And so these are done greater than 7 weeks since the last menstrual period, or a failed medical method of inducing abortion. Okay, this is also taken from your book, Guidelines for Self-Care After Elective Termination of Pregnancy. I would suggest you read that and make sure that you understand it. I'm not saying there's questions about it, but it is something that could apply to a patient you take care of, could apply to someone you know, etc., etc. So be aware of this. Okay, menopause. Now, we've talked about menopause a little bit. It is the complete cessation of menses. Okay, no more menstrual periods. All right. The physiological characteristics and ovulation. That means ovulation does not occur every month. It starts occurring more frequently. So instead of ovulating every month, it may be every 2, maybe 3, maybe every other. It does not necessarily follow a pattern. The menstrual cycles increase in length. So if a woman has been having a 28-day cycle, it may go to 32, and then it may get longer, and then it may get longer. And because what happens is the ovarian follicles become less sensitive to hormonal stimulation from the follicle-stimulating hormone and the luteinizing hormone. Ovulation occurs with less frequency, just like we said, and progesterone is not produced by the corpus luteum, so that is gone. And then your follicle-stimulating hormone values are elevated because it keeps trying to stimulate things and nothing's happening. So that's just a thing that happens with those hormone levels. Physical changes during the perimenopausal, that means the time around menopause is happening. There may be some dysfunctional uterine bleeding, changes in amount, changes in length of cycles, etc., etc. Genital changes, most likely vaginal dryness. There may be some incontinence. The vaginal dryness can interfere with sexual intercourse, making it more painful. Some women get a little depressed because they're no longer able to bear children. They get irritable, have mood swings. But the number one complaint of women that they're going to come to their healthcare provider and complain about is hot flush and hot flash. They're not the same. A hot flush is all of a sudden this woman is she's red. She's just flushed, and she looks like she's been out in the sun and she's been running and her face is red, and she says, I'm smothering, I gotta have some air. And then a hot flash is accompanied by profuse sweating. All right. And women have been known to start peeling off their clothes because they're so hot. Hopefully they don't do this in public, but at home they're standing there and all of a sudden here comes their clothes off, and they're like, I've got to have some air, got to have the fan on. You know, sometimes they want the air conditioner and it's cold enough in there to hang meat. It's so cold and everybody else is freezing, but the mother is sitting there fanning herself because she's so hot. There's a difference between a hot flush and a hot flash. All right, so that is the number one thing that women complain about with menopause, is those hot flash issues. And then, of course, we talked about the mood swings, women that they're happy, women that they're sad. Not unlike some of the postpartum issues, maybe, but it's a whole different ballgame and a whole different set of hormone issues. And then sometimes they, much to their partner's dismay, they're no longer interested in having sex, and they're like, get away from me, don't touch me, that kind of stuff. Okay, so what in the world are we going to do for menopause? Well, there are certain health risks that we need to talk about. One of them is the big one is osteoporosis, okay, and also coronary artery disease, heart disease, because there's a loss of estrogen, which has a big part in all of this. Now we know that osteoporosis, the bones become less dense. There's more space in between in the bone, and so there's like air spaces almost, and the bone becomes very brittle or spongy and breaks easily. All right, so there's a loss of estrogen is one of the big risks of osteoporosis. So sometimes we're going to treat these problems with hormonal therapy. All right, and so we don't do this lightly. We make we sit down. A woman sits down with her healthcare provider, and she makes sure that this is what she wants to do. She is informed of all the risks and the benefits. We know, we've talked already, that some of these hormones, especially if women smoke, can make them more at risk for thrombosis and stroke. So some of the side effects, they can get hot flashes. Even with those, they can gain weight. They may get some headaches. So there's some significant side effects to these things. We can also use, let me give you a few more risk factors for menopause. We also want to make sure that we do a bone density test for these people to make sure we have a little bit of an idea about how their bone structure is, and they're in menopause. So let's talk a little bit more about some of these risks. We've already talked about the loss of estrogen. Other risks for osteoporosis, which we're going to talk a little bit more about here in a minute: Caucasian or Asian race, a small build, a small frame and thin, a family history of osteoporosis, inadequate calcium intake, smoking, alcohol abuse, and long-term steroid therapy is also implicated in the development of osteoporosis. Okay. So here it talks about the bone issues, and so they're very susceptible to fractures, particularly those that are little ladies that are thin and they have that kyphotic appearance to their spine. Vertebral fractures are very common. Just a slight jar against something, bumping into something, even a caregiver just grabbing the individual, maybe not meaning to be injurious, but they are, and they break a bone. So it's very easy to break someone's bone that has osteoporosis. Now we talk about the manifestations. Lots of times women, as they lose bone density, they say that I'm shrinking, and they do, they get shorter. And it's because that kyphotic changes in their spine and their rib cage. You see that far right picture. You see how she's diminished in height. She was 5'6", and now she says she's 5'2". So that definitely is one of those things. And her age, her menopause, all of those things are one of those things that we look at as far as manifestations of osteoporosis. Now, how are we going to treat osteoporosis? We can use the hormone therapy. Estrogen and progesterone are given to the woman who still has her uterus. She hasn't had a hysterectomy. And estrogen in those who've had a hysterectomy. And with these things, with these hormones, we have an increased risk of breast cancers and uterine cancers. And so the woman needs to know that before we start her on some of those. We can also use other medications such as Fosamax, also known as aldrinonate. I think that's how it's pronounced. Actonel is another one. Calcium and vitamin D together. They must be taken together to be effective. One without the other is a waste of time. So calcium and vitamin D for sure. Also a drug named Evista may be used as well. And then of course we want them to use, we help them with, maybe they're going to have some therapy and a good diet and modified exercise and things of that nature for your, your osteoporosis people. Okay, and maybe even for menopause, tamoxifen might be one. Let's see. Okay. Now, let's go on to our next little topic here and talk about structural disorders of the uterus and the vagina. And we've got uterine prolapse, we've got a cystocele, which is a bladder that is not in the right position and is kind of hanging. And we can even have a rectocele, which part of the rectum could be protruding. This is not uncommon in your woman who's had multiple births very close together, all of them been vaginal. She might be overweight. She's a smoker. She's a sedentary. She has not done her Kegels. And so oftentimes we'll have a uterine prolapse, which you see there's various stages here. We've got a normal, we've got a slight, and then we've got a marked. I'm not going to ask you to remember all those, but as you can see, there's one, the last one here. The uterus actually protrudes through the vagina, which can be very uncomfortable, obviously. And so lots of times they may have to actually do a hysterectomy, or we can use a device called a vaginal pessary, Pessary. That's for using for a uterine prolapse. It's kind of like it's on the order of a diaphragm, but not the same. It's actually inserted by a physician, and it kind of, they manipulate the uterus back up into the abdominal cavity, and then they put the pessary there to hold it. And it's left in there for about, I want to say 3 to 6 months, but I'm not sure. And then it's taken out by the physician. The woman is examined. They get a new one, and they're all fitted to that woman, just like a diaphragm is. And then they'll put it in again. For cystocele and rectocele, there's usually it's surgical repair. It's called a bladder tack-up, they call it. They actually take the bladder and suspend it back up where it needs to be, and they sew it in place. Same thing with the rectoceles. Oftentimes, there's urinary incontinence, of course, as a result of some of these issues. And so if the woman can't have surgery for the fact that she's a poor surgical candidate, or she's just extremely obese, and it's kind of, it's really not going to be anything that can help her, of course, she's going to have to wear Depends, and it's very, very embarrassing. And so, what we can do is remember to teach women about how to do their Kegels, if at all possible, so space pregnancies out, at least a couple of years in between, and do your well woman checks so that these can be detected and can be treated appropriately. Here's another picture of the degrees of uterine prolapse. I don't expect you to remember first, second, and third. Just obviously there's one that's really pretty significant. Sometimes there can be benign disorders. There can be cervical polyps, uterine lyomas, leiomyomas, also known as fibroids, although fibroids can grow under the influence of estrogen and can become quite large, can break and bleed, and so those might get treated. Some women actually have bleeding problems with those, as well as that dysfunctional uterine bleeding, and they may go ahead and do a hysterectomy. Oftentimes there's ovarian cysts, which sometimes go away on their own. Sometimes they burst, and then after they burst, the woman doesn't have any more abdominal pain, and the contents will be absorbed by the body, and we don't get too concerned about that unless they're very, very painful and affect fertility and all kinds of things like that. Malignant growths, cervical cancer we know about, endometrial cancer, and ovarian cancer. This is something that, again, you'll learn more about in your med-surg course, but unfortunately, ovarian cancer is very hard to detect. Oftentimes, the symptoms go unchecked until the cancer is well advanced. It's very difficult to detect. There's no test for ovarian cancer. Endometrial cancer, they can go up and get samples. And of course, the cervical cancer, if we do the pap smear as we should, we can often catch that. So in conclusion here, these are some symptoms that should always be reported by your woman, and we need to teach these to our patients, to our sisters, our mothers, our aunts, girlfriends, whatever. Irregular vaginal bleeding, okay? A woman who's had usual regular periods all of a sudden starts having some strange bleeding in between, spotting where she has to wear a pad, and it's annoying and it's kind of scary. She needs to get investigated. Unexplained postmenopausal bleeding. If you got a 70 or 75-year-old woman all of a sudden having bleeding, there's something wrong. Unusual vaginal discharge. That could be from yeast to trichomonas, whatever. Smelly, itchy, whatever, needs to be investigated. Dyspareunia, the painful intercourse. Most of the time, intercourse is not meant to be painful. Persistent vulvar or vaginal itching can go along with that unusual discharge as well. Elevated or discolored lesions of the vulva or the labia, if we want to call it that. Persistent abdominal bloating or constipation. This can be, not always, but could be a sign of ovarian cancer. So persistent is the key word here. Everybody gets bloated from time to time. Everybody gets a little constipated from time to time. But this is something that's persistent, and it's affecting the quality of her life. This needs to be investigated. Persistent anorexia or vomiting, another rather late sign of cancer. And then blood in the stools. It can be visible or invisible. And that's why we often do the fecal tests in the office. They'll do that, or they may do the one they send it home with you, that kind of stuff. All right. Our next topic is infectious disorders, and hopefully a lot of this you have been looking at for your presentations. Candidiasis is also known as a yeast infection. It's not uncommon, especially in diabetic women. It's not uncommon for a pregnant woman to have a yeast infection because the flora in the vagina changes a little bit with pregnancy. And then you have sexually transmitted diseases, and candidiasis can be a result of lots of times you get a yeast infection. We call it a super infection when someone is on antibiotics. So we knock out the normal flora and with the antibiotics, and then we get the yeast. And if a woman has sex while she has a yeast infection, she can transmit it to her partner, but usually there's no symptoms. If there is, they need to be treated as well. And then there's trichomonas, which is another kind of on the order of yeast, itchy, smelly, nasty vaginal discharge. And it can be transmitted from sexual partner to sexual partner, and same way with bacterial vaginosis. Bacterial vaginosis, one of the culprits is Staph aureus. And so the group B strain of strep can also be there. Chlamydial infections, gonorrhea, syphilis, herpes genitalis, human papillomavirus, HPV, and of course your acquired immunodeficiency syndrome, also known as AIDS. Okay, I know that there is a chart I think I pointed out. I hope I did. Anyway, I know there's a chart in your book with all of these, with the Typical signs and symptoms, which you need to know, especially your chlamydia, your gonorrhea, syphilis, herpes, HPV, and AIDS. You'll learn more about AIDS later, so just focus on chlamydia, gonorrhea, syphilis, herpes, and HPV. There's information in your book. I'm not going to go into all this. Make sure you know the signs and symptoms, what the methods of treatment are, and what patient teaching is important. The only one on this list as far as chlamydia, gonorrhea, syphilis, and herpes and HPV. Chlamydia can be cured, but herpes and HPV cannot. We can give the virus, the HPV vaccine, but once you have it, you have it. And the symptoms may go away, but it's always there. Same way with the herpes. You may not have the outbreak of the vesicles, but it's there. And same way with AIDS. Gonorrhea and syphilis, we can take care of them, but they're difficult sometimes because they have a drug resistance at this point. So just know those things about those particular diseases. Pelvic inflammatory disease, or PID, is an infection of the upper genital tract, often caused by repeated infections, repeated gonorrhea, etc., etc. Also implicated in pelvic inflammatory disease development is using an IUD, intrauterine device, to prevent pregnancy, because they think that it can cause some scarring, and then bacteria can get there very easily. There is a chronic pain associated with pelvic inflammatory disease. It's very deep pelvic type of pain. Can radiate into the back. It can be, in some women, it's very almost incapacitating. They can't really do much while they are in this really acute phase, if you will. We have to have antibiotics. We recommend that they remove the IUD and have another type of contraceptive plan. It's unfortunate. The worst part of it is a lot of times there's untreated things like gonorrhea. There's untreated things like chlamydia. And this is where this inflammatory disease often sets up. And so practicing barrier methods for contraception and practicing safe sex helps with this, and not ignoring symptoms of some of your sexually transmitted diseases. Toxic shock syndrome is a life-threatening condition resulting from infection with a toxin-producing strain of Staphylococcus aureus. Contributing factors are women who use high absorbency tampons. They fail to remove the tampon when the menstrual period is over. You could just let your imagination go nuts there. Using double tampons for heavy menstrual flow. None of that is recommended. If you are a woman and you have extremely heavy menstrual flow and you're having to put in 2 tampons, that is not acceptable. Because I took care of a woman who did this, and she put in 2 tampons, and she forgot she put in 2 tampons, and she took one out, and she left one in, and she became extremely, extremely ill. She almost died. I took care of her in the ICU. She had diarrhea that didn't even look like stool. It was almost like water with just flecks of stuff in it, and it poured out of her. And so we were trying to replace her fluids as fast as we can, and just as fast as we were putting them in, they were coming out by diarrhea. It was awful, but she recovered, but she was a mighty sick lady. And so if we need to teach our patients, and we need to do this ourselves, if this applies to you ladies, is if you're having heavy flow, leave the tampons out. Wear a pad. I know it's a nuisance and it's kind of gross and whatever, but be safe and don't get toxic shock syndrome, because it can kill you quickly. Also implicated in the development of toxic shock syndrome is the use of a diaphragm for contraception. The key point here is to take the thing out when you're supposed to after intercourse, clean it, and make sure that you store it properly, and that you wash your hands and all those infection control measures. And then I also put a reference on there for you to look at page 772. And I'm trying to think if there's anything else I need to say. I think that's all. So that is all there is to that. So I will see you Monday.